Good afternoon, everyone. I am Andrea Lavario, Senior Public Policy Advocate with the Human Rights Campaign, and I use she, her pronouns. On behalf of HRC, the Center for Health Law and Policy Innovation of Harvard Law School, the HIV Medicine Association, and the American Academy of HIV Medicine, welcome to today's webinar, Connecting Patients with PrEP, a federal update on coverage requirements. In June 2019, the U.S. Preventive Services Task Force recommended that pre-exposure prophylaxis, or PrEP, be covered by health plans, including individual, small, and large group plans, without cost sharing. The recommendation did not address ancillary services like routine testing and monitoring required for patients taking PrEP. This past July, the Department of Health and Human Services issued guidance clarifying that, and I quote, PrEP is a comprehensive intervention comprised of antiretroviral medication and essential support services, end quote, and the latter must also be covered without cost sharing. In this webinar, we will update you on the HHS guidance, how the changes are being enforced, what health providers and patients can do if they encounter barriers to accessing PrEP, and how implementation of the guidance can help reduce the significant racial and ethnic disparities in PrEP use. Now I'd like to introduce our panelists. First, we have Carl Schmid. He is the Executive Director of the HIV plus Hepatitis Policy Institute, which he formed in December 2019 to promote quality and affordable healthcare for people living with or at risk of HIV, hepatitis, and other serious chronic conditions. Mr. Schmid has been a national policy and advocacy leader in the HIV community for over 20 years and spent 16 years as the Deputy Executive Director to the AIDS Institute. Mr. Schmid has expertise in healthcare financing systems and leads policy efforts to ensure that domestic HIV and hepatitis programs are based on sound public policy and fully funded. He has served as co-chair to the Presidential Advisory Council on HIV and AIDS, also known as PACHA, and currently serves as a member of PACHA. And he is also a consumer representative to the National Association of Insurance Commissioners. Mr. Schmid is a cancer survivor and living with chronic hepatitis B. Dr. Marwan Haddad is chair of the board of directors for the HIV Medicine Association. Dr. Haddad is also the medical director of the Center for Key Populations, having joined the Community Health Center in July 2006. He earned his Bachelor of Arts degree from Harvard College and his medical degree from McGill University. Dr. Haddad is board certified in family medicine and as an HIV specialist with the American Academy of HIV Medicine. Since January 2012, he has led the CHC Project ECHO, HIV, hepatitis C, and buprenorphine programs, which expand the integration of these programs not only within CHC, but nationwide. Dr. Haddad has taught and lectured at state and national conferences on HIV, hepatitis C, medication-assisted treatment, and substance abuse management and integrated care. Next, we have Dr. Christina Madison. She is an associate professor of pharmacy practice at Roseman University of Health Sciences, where she is a clinical pharmacist specializing in public health with a focus on infectious communicable diseases. She is also the founder and CEO of the Public Health Pharmacist, a public health consulting firm. Dr. Madison maintains 2 active practice sites with Hunt Ridge Family Clinic and Volunteers in Medicine of Southern Nevada. She has been caring for those affected and infected with HIV for over 15 years in the Las Vegas metropolitan area and has been credentialed by the American Academy of HIV Medicine since 2013. Dr. Madison is a trusted and valued healthcare professional who has been asked to share her clinical, public health, and infectious disease expertise with local, state, and international media outlets and NGOs. Next, we have Tara Smith, the Primary Care and Affordability Director at the Colorado Division of Insurance, where she helps lead the division's payment system reforms to reduce health costs for consumers by increasing utilization of primary care. She is responsible for recruiting, convening, and facilitating activities of the Colorado Primary Care Payment Reform Collaborative and in developing affordability standards and strategies to help ensure commercial insurance companies' investments in primary care drive better value and quality for consumers. Tara has been actively involved in efforts to reform the state's healthcare system throughout her career, including Colorado State Innovation Model and implementation of the Affordable Care Act's health insurance marketplace reforms. Moderating today's discussion is Marianne Tomasic, clinical instructor at the Center for Health Law and Policy Innovation of Harvard Law School. Off to you, Marianne.
Thank you so much, Andrea, and welcome everyone to today's discussion. A couple housekeeping points to start. We have a pretty sizable group today, and to help keep our panelists and those speaking up front and center, we've spotlighted ourselves on the webinar so that you can see the entire panel pinned in your screen. But if you happen to have a different version of Zoom, you can also go ahead and click on the view button on the upper right-hand corner of your Zoom video and select speaker view, and you will see whichever panelist is speaking at that time. And as you may have seen on the previous slide, we invite everyone to drop questions into the chat. We have some questions lined up for our esteemed panelists, but I will also do my best to incorporate the questions submitted in the chat into our discussion today. So to start off, thank you panelists for joining us today to talk about connecting patients with PrEP, a federal update on coverage requirements. We thought it might make sense to do some initial level setting, and let's talk first about the coverage requirements for PrEP and what the new federal guidance did this past summer. And Carl, I was hoping you could lead us through what happened.
Sure, thank you, Marianne, and thank you, Andrea, and all the organizing groups for today's session. So to start with, you really have to start with the Affordable Care Act. And one of the provisions in the law was coverage of preventive services. And of course, everyone wanted their preventive service covered. I know we were up there trying to get HIV testing covered, others, other preventive services. And so Congress said, wait, we don't want to deal with the one-on-one. We're going to say whatever is approved gets a certain grade from the U.S. Preventive Services Task Force. And that's a grade A and B. The task force is an independent body that looks at they look at preventive services, and they recommend those that should be offered in primary care settings. And so they review the data, look at the harms, the benefits of these preventive services. So Congress said, we're going to let the U.S. Preventive Service Task Force guide which plans have to cover these services. And so it's not only cover, but it's also cover without cost sharing, because Congress wanted, we spend so much money on, when people are sick. Congress really wanted, through the Affordable Care Act, to prevent illness. And so it's great that they did this. So, PrEP was approved, the first drug for PrEP in 2012. And it wasn't until June of 2019, 7 years later, that the U.S. Preventive Service Task Force completed its review. And I'm getting a background feed. I don't know if anyone else is getting that too. Okay. So it wasn't until then that it was approved, gotten its grade from the U.S. Preventive Service Task Force, a grade A, which is great. So then plans, and it's not all plans, it's only those plans that follow the essential health benefits. So it's non-grandfathered individual and small group plans. And so there are a certain segment of private insurance plans that are not, that don't have to follow this under the Affordable Care Act. So plans also have some time. They have, they don't have to cover it immediately. The way the regs are written is you have, it's the first, when your plan is renewed for its the next plan year. So by January 2021 is when all plans had to start covering PrEP without cost sharing. And so that was almost a year ago. But there was we in the advocacy communities were concerned that plans needed more guidance. And actually, some states went ahead and issued guidance on their own and said, New York said, oh no, you have to start covering PrEP without cost sharing immediately after the US Preventive Service Task Force grade came out. Other states also issued guidance and said that you have to cover ancillary services as well. But we had a patchwork of different states, some states doing something, other states doing nothing. And so we know that PrEP is just not the drug. It is medical visits, it's lab tests, it's periodic HIV testing, STI testing. And those also had, cost sharing associated with it. And we said to the Department of Health and Human Services, we need guidance to go out to the plans that they have to cover all these ancillary services as well without cost sharing. And so that finally came out this July, and to all insurers to say that. And since all plans probably didn't know that, even though I think they should have known it, they gave them 60 days to enforce that, for state insurance commissioners to enforce it. The other things that guidance also said is that there should be no limitations on how long someone can take PrEP or not. They can do prior authorizations because, there's generic PrEP, there's Truvada, there's brand Truvada, and there's Descovy. They can do prior authorizations, but they have to handle those expeditiously. And that means very fast, in a day or so. And it's really up to the provider to decide on what drug the patient should receive. So, and just to wrap up, they also said that you have to cover at least one of those drugs. You don't have to cover every single form of PrEP right now, but you have to cover at least one without cost sharing. And if you can't take that one, the provider can go through an exceptions process, and that also has to be covered without cost sharing. So that's basically what the US Preventive Service Task Force did, and also what the guidance did from the federal government.
That was a really helpful explanation, Carl. And it sounds like there's a big move to cover PrEP, and then some details needed to be ironed out, and I imagine still need to be ironed out. I want to turn to the providers on the panel, Dr. Haddad and Dr. Madison, to talk a little bit about PrEP and its role in public health and the healthcare system. Why is PrEP important, and what kinds of barriers do people face when accessing it, and what disparities do we see? Dr. Haddad, maybe you can go first.
Sure. So again, thank you, Andrea and Marianne, and for inviting me to be here. So first, we can start with why is PrEP important, and why should we care about PrEP? And well, we have great evidence to show that PrEP is as effective, if not more effective, than condom use in preventing sexual transmission of HIV. So PrEP, when taken as prescribed, I think as all of us know, can reduce sexual transmission by 99%. Yet we've been ingrained to think that condoms are the only responsible way to prevent HIV transmission, right? For years, all we've been saying is condoms, condoms, condoms. So it's a paradigm shift for us as a medical community to say you don't have to use condoms to prevent HIV transmission. But PrEP use is being responsible, right? It not only prevents people from HIV acquisition, as well as, if not better than condoms, but it also improves people's quality of life and quality of sexual pleasure and intimacy. So with PrEP, we had for the first time in our HIV prevention toolbox, something that did not involve a physical barrier to intimacy. So how great is that, right? With PrEP, you can have both prevention as well as intimacy and improved pleasure. In addition, with PrEP, women with HIV or with partners with HIV can get pregnant when they want without worrying about HIV transmission. So I've seen people asking for PrEP being told they should still be using condoms without much more of an explanation, or even people who are on PrEP being judged and scolded for not using condoms, right? We should be commending people for taking control over their health and using PrEP to prevent HIV, period. And then we can also inform our patients that PrEP protects really well against HIV, but not other STIs. And for now, if they'd like to protect against some of these STIs, then condoms are a really good choice. So then why, if PrEP is so effective, right, do we have only 23% of the estimated 1.2 million people who could benefit from PrEP in the US actually being prescribed it? And this 1.2 million people, by the way, includes not only men of sex with men, but also people who inject drugs and heterosexual individuals. So definitely we need to increase PrEP uptake among all people who are at risk for HIV, since the uptake is so low across the board, but with a particular focus on the groups who have disproportionate rates of new HIV infections. So men of sex with men, particularly Black and Hispanics, who are the majority, who comprise 70% of new infections. And then Black women, who are at the highest risk group after men of sex with men, and people who inject drugs, right? A group of people whose HIV rates are going in the wrong direction. Rates are increasing rather than decreasing given the opioid epidemic that we're in. So, and when we delve further into these disparities and the uptake, we see more PrEP use among men than women. So 26% of eligible men are on it, but only 9.5% of eligible women. And more use among white men than Hispanic or Black men. So just over 60% of white individuals who can benefit from PrEP are prescribed PrEP, yet only 14.5% of Hispanics and 8% of Blacks. So that brings us to why. What are the barriers then to PrEP uptake? And unfortunately, there are many. So first, for providers, there's still a lot of stigma and discrimination. So providers overall tend to be either too embarrassed or too uncomfortable to talk about sex. Some who are not are too busy to ask about sex or take a good sexual assessment. Most are not trained well in how to take a proper, relevant sexual history, but we know that if we as providers ask about sex in a non-judgmental tone, explaining why we're asking these questions, most patients welcome us to do so and actually want us to. But the moment we give off any side of judgment or discomfort, right, the idea that unprotected sex is deemed irresponsible, or having more than one partner is promiscuous, or having trouble saying the words anal sex, right, so on and so forth, our patients will not tell us anything about their sexual health. And so add on to the stigma of being gay or transgender that still is out there, and layer in race and ethnicity, and then you've got that perfect storm we're seeing with low numbers of PrEP being prescribed and the racial and ethnic disparities in the PrEP uptake. But another barrier that many providers are not aware is that providers are not aware of PrEP and its effectiveness, or they don't know enough about it, thinking that it's medication treatment that should be prescribed by an HIV specialist, right? Since it's an HIV medication, or that it's recommended only for gay men, and so not considering the other at-risk groups for this. But it is safe, easy, and effective medication that can be prescribed by providers such as primary care and OB and others, and pharmacists, right, Dr. Madison, and frankly, should be, right? Prevention is in the wheelhouse of primary care, for example, but we need to educate and train. We need to train on talking about sex and taking a sexual history to HIV prevention tools, particularly PrEP. And for those who may be willing to prescribe, there's an issue of not having enough time during a visit to address sexual history or prevention. And there's also difficulty in identifying people eligible for PrEP. And among other things, this is sort of tied to lack of HIV testing. So here I want to touch upon the need for a more robust and diverse workforce. Right? Patients and communities are not seeing themselves reflected in the healthcare services or the providers that are available, and that leads to the lack of engagement, lack of access, lack of trust, and further widens the disparities that we're seeing. Okay, and so from the patient perspective, high on the list, of course, of barriers, again, is stigma and discrimination that prevents them from asking about, seeking, or accessing PrEP. Many may not be aware of its effectiveness. Many may have misinformation. Many may not see themselves as at risk. And there's also stigma even from within the communities they belong to. And for those who may be aware and want PrEP, they may have no idea who they can access treatment from. This highlights the need to expand PrEP to as many access touch points as we can, right? Allow pharmacists to prescribe it, have nurse-led clinics, all levels of providers, including PAs and NPs. Think about mobile vans, teleprep, at-home testing. So many of these innovations have come out of COVID and should be looked at and used to deliver HIV prevention and PrEP. And of course, for patients, another barrier are the costs associated with, as we talked about, the PrEP medication, the visits, the lab testing, and these costs, or the shared costs, That deters people. And all of this could be prohibitive. And lastly, the barriers related to the structure and the processes that we have in place. How do we identify the qualified individuals for PrEP? How do we link them to PrEP care? How do we get them on the treatments and get them tested regularly? And how do we keep patients engaged? How do we ensure clinical teams and providers prioritize this, have the time to provide these services and deal with all the competing interests and priorities that they have? And the answers, I believe, really bring to light the importance of the ancillary services that are essential, right? Be it adherence counselors, outreach, having a PrEP navigator or an equivalent point person, IT for setting up the clinical dashboards and screening for HIV programs that we can set up. So at the end of the day, I think if we each ask a few questions about sex of our patients, we screen them, offer PrEP to those at risk for HIV, the access will increase and uptake will increase. We need to demystify this, right? I know that I may now be oversimplifying, but when it comes down to it, it's simple. We need to be patient-centered. We need to treat our patients with dignity and respect, with no judgment, and offer them the proven evidence-based treatment that is effective and safe. We just need to do it.
Marianne, we are unable to hear you.
Sorry about that. Thank you to Dr. Haddad for sharing that, and switch over to Dr. Madison to see if you could share some of your experiences in expanding access to PrEP and some of the challenges that you've seen in the field.
Absolutely. So just wanted to echo Dr. Haddad's sentiments and all of the amazing things that he just mentioned. But again, just want to say again, PrEP care is not specialty care, it's everyone care. Because the last time I checked, we all like to enjoy sex. So this is one of those things where we really just have to start getting comfortable having that conversation. And for me personally, that's one of the number one things that we talk about at our clinic is, asking that question about sexual history is, how do you enjoy sex, right? And so many times we have patients that are so shocked that we're asking the question in such a positive manner because of the stigmatization around sex and sexual behavior, sexual orientation, or even just, the thought process around someone engaging in transactional sex, or somebody who is, who works in the adult film industry. I live in Las Vegas, Nevada, and we have a lot of people who work in the adult film industry, and we want them to be able to work safely. And that includes access to PrEP care, because again, PrEP care is primary care. It's not specialty care. And so for me personally, I think the biggest barrier is just lack of education in just general providers around the benefits of people being on HIV prevention, because they think that it's this specialty that only people who are infectious disease specialists, or only those individuals who care for those with a positive status should be prescribing PrEP, which ultimately is not the case. And the other part of this too is lack of awareness in communities of color. So for me, as a woman of color, that has been my biggest thing that I've wanted to get out there, because not only are we seeing lack of awareness in communities of color, but in particular Black women, because of this thought process around not having a risk, or even in our WSW population or our lesbian population, not thinking that they're at risk as well. And so, I think unfortunately, there's been two things that have happened during the pandemic. So we have, really focused heavily on the COVID-19 response and vaccinations. But what we need to be thinking of is, PrEP care is just like a vaccination. It just happens to be a medication that you can take on a daily basis to prevent you from getting HIV. And so when we think of it more in a very simplified way. So, or even just looking at it from a standpoint of like birth control, like we take birth control to prevent an unwanted pregnancy. Why can't we think about PrEP care the same way? And even just post-exposure prophylaxis is like Plan B, right? So all of these things combined are going to help us to end the epidemic. And we need to get the information out in front of those who unfortunately could benefit from it the most, but are unfortunately not seeing the messaging because of a lack of perceived risk or lack of access because they think that it is financially prohibitive. And as Carl mentioned, we know that these insurance plans now need to cover these services. And in my state in particular, we've now implemented legislation to allow pharmacists to prescribe HIV prevention strategies, which includes both PEP and PrEP. And this is another access point as one of the most accessible healthcare professionals that people can now seek instead of having to feel like they have to go to an infectious disease specialist or an HIV provider. Because again, this is primary care, this is not specialty care. And so when we improve access to care through things like telehealth, telemedicine, pharmacy clinicians, nurse practitioners, other points of access, as well as informing the public that can benefit from it most, that is when we really are going to hopefully see this prevention strategy doing what it is meant to do. Because ultimately we know behavioral modification alone is not enough, as well as treatment as prevention. Because although we know U equals U, there are still people that even though they know their HIV status and are in care, unfortunately are not yet undetectable. So we still need that extra layer of protection that PrEP care affords us. And again, we know that these therapies are highly effective. Interestingly enough, right before we came on for this webinar today, we were all just talking about the new PrEP guidelines that were just released for 2021, highly anticipated, and now also include a long-acting injectable. So again, there are so many things to be excited about when we think about how we are going to see this epidemic end in my lifetime. And I can't tell you how excited I am as a pharmacist to really be able to provide that optimal patient care, not only for patients that are traditionally seen as at risk, like our sexual and gender minorities, but really thinking about our BIPOC community, our Indigenous brothers and sisters, our AAPI brothers and sisters, which often feel left out of this scenario and often don't feel like their needs are being met. I think that utilizing all partners within the healthcare team and really looking at this as an interdisciplinary care approach, because again, it takes a village for all of us working together to make this happen and to make access to those ancillary supplies and testing and labs and counseling, all of those things combined, as well as paying the clinician for their clinical services. So that was part of the Nevada legislation as well. And so our Nevada Medicaid, as of January 1st, will now reimburse pharmacists for those clinical services, as well as making sure those ancillary services like labs, STI screening, as well as counseling and condoms, which we were able to get written in the law. So now pharmacists can prescribe condoms and they will be paid for by Medicaid. So all of these things combined, not to say that you have to have condoms, but it is another layer of protection. And especially if you're engaging in commercial sex work, we want to make sure that if you don't know the status of your partner, there are other ways that you can protect yourself on top of using PrEP, because PrEP therapy alone does not protect you against sexually transmitted infections. So just to summarize everything that I've talked about, PrEP care is everybody care. We all need to start feeling comfortable talking about sex, and why people should be talking about it and how they're enjoying it safely. HIV prevention is only just one pill or potentially one injection away, and we can all get access to it. And we now know that having additional resources like pharmacists are just another way that we can provide additional services and resources to our patients who so desperately need us, and especially those in the BIPOC community, our Indigenous brothers and sisters, women of color, as well as our sexual and gender minorities. And again, awareness and knowledge is power. And so the more we talk about it, the more we scream it from the rooftops, the more we can get those who need this service and can benefit from it most, the resources that they need.
Thank you so much, Dr. Madison. There's some questions popping up in the chat, and I thought that one comment noted that some of the smaller insurance companies aren't necessarily covering PrEP without additional cost sharing because they're failing to recognize PrEP as preventive. So I want to ask Tara how state officials are helping ensure expanded access to PrEP and ancillary services, and how officials are monitoring and enforcing compliance with the new FAQ. And I'll also flag that another person commented that costs can be collected at multiple points. And so to what extent does enforcement of no additional cost sharing look like at each of the components of the PrEP paradigm, including providers, the pharmacy, at the labs, et cetera?
Great, thank you so much. I feel like transitioning from we need to talk about enjoying sex to insurance regulation is now going to be an even more abrupt kind of right turn in the conversation. But thank you all. I'm really happy to be here and to be part of this panel. Really, to do effective insurance regulation and enforcement and compliance and monitoring, we need to have a very open conversation with providers, with the people who are involved in direct patient care, understanding your issues, your challenges, the barriers that you're hearing, in order to make sure that we are able to be bringing the tools that we need to bear to make sure that individuals are able to access the coverage they need. I think to back up just kind of take it back quickly to the 50,000 foot view, as a regulator, when we're thinking about PrEP coverage, it's really through the lens of consumer protection. And so as a division of insurance, in Colorado, our primary mission is to ensure the protection of Colorado consumers. And we do that, one, by ensuring that consumers have access to the health benefits in their plans. So that includes our consumers able to easily access those benefits, are consumers aware of those benefits, are there providers within carrier networks that can be providing those benefits. So thinking about access comprehensively. Another key component that we look at is also affordability. And that's not just affordability in the sense of, are people able to afford their health insurance coverage, but once they have that, are they actually able to utilize the benefits are within that? And that's why the conversation about PrEP and about preventive benefits and having USPS, TFA, and B recommendations covered at no cost sharing is so important and such a focus of our work. We know that even when individuals have health insurance, any type of co-payment, any type of co-insurance can be a financial barrier to them actually wanting to access those services. So as we hone in, I think Carl did a great job of kind of outlining the actual plans that we're talking about. So these are plans that are subject to the Affordable Care Act and that are within the jurisdiction of the Division of Insurance. So that is a pool of plans that are fully funded, that are private, commercial, are kind of the words that you'll use here to describe these plans, which is a subset of the market here in Colorado. Kind of fully funded plans are about a third of the market. Self-funded or large employer plans that pay for their own benefits or RISA plans are about a third of our market here. And then public insurance are kind of outside of our scope. So honing in on that third that are the ACA requirements, it really is a combination of federal and state regulations that construct the regulatory framework, which really are the backbone of our compliance, monitoring and enforcement mechanisms. And so Carl did a great job again of walking through the ACA, establishing the requirements around the A and B recommendations. That certainly is kind of the federal floor, but states then that have the jurisdiction over fully funded plans also have authority to increase regulations. And then Carl mentioned there was also a kind of smattering approaches after that initial approval of the recommendation back in 2019. I am happy to say Colorado was not on the end of the spectrum that did nothing. We have tried to take a pretty proactive approach to ensuring that carriers are aware of the coverage requirements, that they're communicating that to their plan members, and increasing consumer awareness around coverage. So we did that through state regulation, which went into effect on 1/1/21. So once that coverage requirement was in, there was a Colorado regulation in place, which directed carriers that they need to be covering PrEP. And we explicitly in our regulation listed the CDC guidelines around who was eligible and should be receiving that treatment. So had a robust regulatory structure in place at that time. We did on the topic of ancillary services, that was of concern to us, right? It was not addressed in that initial recommendation. So concurrent with that regulation, we also issued a bulletin. So in regulatory insurer speak, a regulation is something that is implementing a statute. So it has the force of law. So if a carrier is not complying, we can bring our full component of enforcement mechanisms and penalties. A bulletin is a statement of it's the division interpretation of an existing statute or direction around general division policy, but it is not binding and it does not establish enforcement of rights. So it's the way that we can put forth our expectation and strongly encourage carriers to be taking an action. And so we issued a bulletin that strongly encouraged carriers to also be covering ancillary services at no cost. With the recent passage, we were thrilled with the recent passage of with the release of the FAQs. And so we are actually currently in the process of updating our previous regulation to now make coverage of ancillary services part of that requirement. So it's becoming a binding part of Colorado statute. We are actually having a hearing on that on January 4th of next year as part of our rulemaking process. So we'll hopefully get that in place just as soon as we can. When it comes to enforcement and monitoring of things like coverage or these types of benefits, the division really is taking a two-pronged approach. One is by proactively reviewing carrier plans. So as part of the ACA, the individual and small group plans that Carl mentioned file their plans with us annually, and we go through a review process before approving those for the following year. And so in 2021, we did a detailed review of those carrier plan filings to make sure all carriers were providing appropriate coverage of PrEP at that time. So very proactively trying to make sure that carriers are addressing it. We found that in some of the way that plans are filed, that coverage was not always clear in the types of documents that carriers submitted, particularly around their formulary. And without getting into the weeds around how we actually review formularies and making you all regret inviting an insurance regulator to your panel, basically there was not the flexibility or nuance in the tools that we were initially using to collect that information. So we contacted carriers, asked them very specifically about their coverage and how they were communicating that to their plan beneficiaries. So was that in their statement of benefit forms? Did they include that special notification in the formulary documents that were going out to their plan members? So very intentionally trying to make sure that not only was coverage appropriately and in place, but would someone purchasing that plan be able to find it, right? Is it buried on page 305 of my benefit form in language that I don't understand? Or is that pretty clearly displayed that when these medications are used for prevention of HIV, they are covered at no cost sharing? So are taking actions there. The other place we do this is through monitoring, so through complaints. So that's whether that is an individual who has cost sharing imposed, whether that's someone who has a benefit denied. Really encouraging, again, that's the consumer awareness piece, but also encouraging those individuals to follow up and let us know. As regulators, the way that we primarily know that people are not complying with the regulations and the framework that we have out there is for people to let us know. So certainly for patients that you see that are running into issues, please have them contact their state division of insurance. I can promise you those regulators want to know. As providers, I would offer the same advice. If you see, you probably have a better kind of scope-wide view of your practice to see if there's certain insurance companies that where you're seeing this pattern either of denials or the imposition of cost sharing that's inappropriate. Contact, if you know the consumer line is usually pretty publicly available, that may be the route that you use to describe the issue that you're seeing, and they can connect you to the right resources in the division. So I would say kind of the three big buckets are: one, making sure as a state you have an appropriate and strong regulatory structure in place; two, being as proactive as you can to make sure that the plans that are entering the marketplace are in full compliance with regulations, even prior to them being sold in the marketplace; and then three, really proactively trying to monitor that, whether that's through complaints. Another strategy that the division has been involved in is really getting engaged with some of the consumer advocacy organizations in the state, whether that's for LGBTQ+ or whether that's for people that assist consumers with health insurance, but really creating open lines of communication there so we can be hearing what the issues are, what the problems are, and be taking the appropriate action to correct them. And Marianne, I think that was part B to the question, but I have now talked myself into forgetting what that was.
No, that was great. And in fact, it kind of went into the next question I was going to ask, and then I'll still ask it again because I think it's so important, is that when a provider hears that their patient has been charged for PrEP or for lab testing required for PrEP, what would the next step be for the patient and for the provider? Is there a final recourse that exists with the state, and are there avenues for providers and their billing specialists who know of specific insurers who are requiring these charges and then reimbursing as if it's a pattern, and requiring people to go that extra step before they can get the benefits of the ACA in this area? Are there avenues for providers to connect directly with folks at the Division of Insurance in Colorado, for example, so that these issues can be addressed a little bit more efficiently and not put the burden on patients?
The answer is yes on both of those counts. I would certainly encourage provider, if it's a specific patient, to try to work with that patient to go ahead and report that through a consumer services phone number. There's kind of immediate assistance there that can be activated, and depending on the nature of the issue involved, is it just an inappropriate charge share? Is it something where something was denied on medical necessity? Kind of the nature of the reason why the service was not provided at no cost sharing in the way it should have been may determine different avenues for how that complaint would get resolved. But to certainly get an individual access as soon as they can, I would still encourage providers to work with individuals, have the number for the Division of Insurance somewhere pasted on the wall in your office, something that is easy access where you can be helping to refer that. For providers, very much want to have that same open line of communication. There is not kind of the direct provider phone number that we have in Colorado, but certainly they are welcome to call and talk to. The initial route, easiest route, is probably through that consumer services line. And then that call will get directed to the appropriate people that would need to help resolve the issue. When we see a pattern of complaints with a specific insurance company or in specific areas, that can lead to a market conduct review. So if there's a pattern or practice that is established, there's actually a separate process outside of necessarily resolving an individual complaint that takes that broader scale look, whether that's at a carrier or a specific practice. And that is a different division that would get notified and looped into that kind of response. But certainly but something we're going to want to know about, right? And knowing that early can help us identify. And then if we see the pattern increasing, really get that market conduct in place in the way that we need it to, which brings a kind of different set of enforcement mechanisms that we have that are also pretty powerful in correcting practices, particularly that are starting to occur at that systemic kind of level. They're becoming a pattern.
That's helpful. And I think I've been keeping an eye on the chat. And one of the takeaways that I've been getting from some of the comments and questions is that this is great, but we need more. And so I want to open it up to the group and talk a little bit about how PrEP and expanded access to PrEP and ancillary services fits into advocacy and state national government efforts to end the HIV epidemic. What more do we need? I mean, it seems like we need more conversations about coding between the payers and the billing departments. We need education so that people know that they should not expect to pay a bill, and so they know to fight it and they know to raise it up as an issue. We've talked about the important roles that PrEP navigators play and having someone to help patient understand all of the different parts of preventive care. And we've also talked about the need to address some of the disparities that we see in PrEP uptake, and including more targeted efforts, better education, a more diverse workforce that reflects the people that they're serving, et cetera. So I guess I'll open up to everyone is to, what's next? What more do we need? And going forward, how does this fit into some of the other issues coming up, for example, future approvals of long-acting injectables and long-acting PrEP?
So I'll start. So you hit the nail, Marianne, with all the things that we need. And I think the speakers have all done a great job to say, even with the things the tools that we have right now, we still need a lot of help to implement them. And just the lack of knowledge. I think it's a shame that any insurance plan is not doing a good job of putting this on their formularies so that beneficiaries know that it's for free, that their PrEP is for free. And then also, I get reports all the time. I got one today, someone from Texas, from a very large insurer, I won't mention their name, but a very large one, that they were getting their PrEP drug for free, but they were still being billed $200 for their lab services. And so encouraging them, to talk to their insurance commissioner. And Terry, Colorado's been great, and I wish every state was just like yours in making sure that the plans are doing this. So we need enforcement, and we need the regulators, to be doing that. And but we need to educate not only the community at large, the candidates for PrEP, but providers as well. And, I think the theme of today is, talk about sex. And that's a big issue. We have HIV testing as a U.S. Preventive Service grade A already for years, but we're not implementing that. When's the last time people went to their doctor's office and were offered an HIV test on a routine basis? And so, and also one of the keys that we've been talking about is this only applies if you have healthcare coverage. So what about all the people who don't have healthcare coverage? And so, we've been working and with a number of groups, with a number of congressmen and women on the Hill to put forth a national PrEP program. We need further education. We need providers and community. We need outreach. We need toolkits. But we also need something to pay for PrEP drugs and ancillary services such as adherence for those who still have cost sharing, like in Medicare, and also for all the people who are uninsured and can't get insurance. So there's some bills that have just been introduced in the House and the Senate, And and it would, and I know we talked about a little about the future, that we are gonna, and I saw this come up in the chat too, there will be, hopefully in the next month or two, an injectable HIV prevention tool. It will be every 2 months, but we're gonna have to go through the process again through the US Preventive Service Task Force. Plans will start covering it. That's the responsibility of their manufacturer, talking to the payers, get it on formularies. But then we're going to have to go through the process again. The U.S. Preventive Service Task Force has to review it. They're starting it already, which is great. The drug hasn't even been approved, and they're starting the process already because we pushed them to do that. But then it's time to get it implemented, to get before that all plans have to cover it and without cost sharing. And so there's still a lot of work to do. And I appreciate being here. Thank you.
Hopefully it won't take another 7 years, Carl.
And that's what we want. That was, and they are moving forward, and we know that there's going to be more drugs down the road. And we want a process that we can build those in quickly and people don't have to wait years.
And, just to add to that, and I think, Carl, those are, fantastic, the national sort of, plan for PrEP. I mean, look at what has been successful, right? Look at the Ryan White programs. And we know that they do it right? And so we can learn so much about how we can do PrEP by looking at the Ryan White and looking at all those sort of services. We've got Ryan White, sort of programs at my health center, and the way that we have the resources that we have, from case managers to care coordinators to resources to support medications and testing and so on and so forth. That works. So let's use it for PrEP. I think look at the safety net. And how we sort of do this, at my health center, we use Quest, and at Quest, anybody who fits a particular sliding fee scale does not pay a cent for any labs done. And so you could sort of look at all these different resources that have been working and ensuring that we actually get our patients who are at risk in and getting the services that they need. I think we don't need to reinvent a lot of this. We know that there are programs that work, but let's be able to use those programs in a way that we can start to incorporate PrEP into them.
Also, just want to say, from a legislative standpoint, a lot of these things, like in Washington State, like they've legislated into the state legislature that they have to pay for PrEP services. And so, Elise Tong, who is also a clinical pharmacist, and Kelly Ross Pharmacy, like they've been doing PrEP care since 2014, I believe, or 2015, and they've had a very robust PrEP care services, and they've been able to make it work because they have the legislative backing in order to support them, because they have the funding in order to do so. But if you don't have that backing, it makes things so much more difficult. And so again, some of this may just be going back to the drawing board and finding those legislative champions to really help you to get some of these things put in the law, so that you can't, deny people care, because it is in the law. So just wanted to say that as well.
And we're looking at really the push, I think, in legislatures and certainly in Colorado toward health equity that's really come out of COVID. Can we capitalize on that and really be putting that into meaningful policy change with things like PrEP, with actually looking at coverage that is meeting people's needs, that's meaning whole health, right? That's looking more comprehensively and making sure we're putting those components in place. I also love that this is part of primary care, which appeals to, some of you may have noticed that in my title. I also work on regulation and legislation, but certainly this is coverage that is for everyone, not just populations.
Well, in the same vein of legislation, I'm actually going to turn it over to Andrea to talk about some of the bills that are currently before Congress that have to do with PrEP. Andrea?
Sure. So the clear takeaway this afternoon from our expert panelists is that we must expand access to PrEP, particularly in the communities that have been hard to reach. And while we have established government programs that are funded to treat HIV, a comprehensive nationwide program dedicated for the provision of PrEP is also needed. So we have been working closely with allies on Capitol Hill to draft legislation that moves in that direction. And these two bills, the PrEP Access and Coverage Act and the PrEP Assistance Program Act, have both been introduced. They both establish programs to provide grants to states, Indian tribal governments, federally qualified health centers, rural health clinics, local governments, CBOs, to establish and support PrEP programs. The PrEP Access and Coverage Act actually is a little bit broader. It would also eliminate out-of-pocket costs for PrEP and associated costs and lab fees, prohibit prior authorization requirements for HIV prevention drugs under private and public health insurance, prohibit denial of or premium increases for other types of insurance like disability, life insurance for individuals who are taking PrEP. And it also includes directed public and provider health education campaigns to increase utilization of both PEP and PrEP. So we would encourage all of you to reach out to your members of Congress and urge them to support these important HIV prevention bills. And with that, I'd like to close out by thanking our panelists for sharing their time and expertise with us today. We hope that the information provided will assist you in reaching patients who would benefit from PrEP and to ensure that those individuals are able to access PrEP without cost barriers. Thank you, everyone.
Thank you so much.